I'm Harry van Piekert, and I want to give you a short CRAFTA intro lecture about what we're doing and where we give our courses. I'm self coming from Holland. I'm working on the University of Applied Science in Osnabrück. I have known practice, what you see here, and I teach a lot and also do some clinical research on pain and craniofacial pain and temporomandibular joint disorders. So I want to give you a short lecture today. What for patients we see if you do CRAFTA certificate education. Secondly, what is the current evidence and where we stand for as CRAFTA education, and how are patients examined and some takeaway tools. So let's first look to where we give our courses. Our courses are in more than 40 countries, especially in Europe, and the last 4 or 5 years also in the US and in Canada. And it is a specialized education for physical therapists, speech therapists, and dentists. You find more on the website. So the patients we are focused on is special on one part, pediatrics. Yeah, children with headache, children with oculomotor dysfunctions. We also look to the rest of the neuromusculoskeletal signs and symptoms. And another thing is, of course, the special orofacial pain patients. And that can also be younger people, but also older people who comes in with temporomandibular joint dysfunction, neck pain, diffuse pain in the cheek, in the eyes, etc. And another thing is, of course, in part the children and the patient who get balance dysfunctions and headache and face pain by dysfunctions of the eyes, but also post-surgery, what you see on the right side. So what does CRAFTA stand for? I think it is an international approach to neuromusculoskeletal pain and dysfunctions, where we are very open-minded. So it is not really a recept education or therapy. We are very focused on functional and active rehabilitation approaches. So we do something with hands-on manual therapy, but we do also, of course, coaching the patient and give the patient a systematical training. That can be brain training, it can also be activities. And we assessed it and reassessed it. More than it's only TMJ, it is not only treating the joint, but we see the TMJ as a part of a chain who can also may be a possible problem. And of course, we have to start by children. We learn, of course, a lot of children. And if we can prevent something in physical therapy, in neuromusculoskeletal therapy, we can start with our children. Another thing is, of course, we are coaching. We are not only doing and have an education from hands-on, and we take, of course, the international or the internal and external evidence. So we take what's coming out of the literature, but we also try to be innovating. Yeah, we create some things what is related with the secondary, the evidence from the literature, and make our thoughts about it. We integrate modern pain mechanism models, and it's very exciting. I want to start also later on with something to talk about the trigeminal sensitivity. And we also look to other things, not only TMJ, but we also look to cranial neural system and also to the craniofacial system. And last but not least, we are also very interdisciplinary. So we start, or we want to cooperate with other doctors like dentists, oral surgeries, pediatrics, psychologists, etc. So the course we have in English, maybe a 5-day course, 2 times, with e-learning of 18 hours. And it can also be that we have now a hybrid system also, that it can be that you have an education from online 7 hours 2 times. And then we see altogether live 4 days on the call center in block 1, and in block 2 also for 4 hours. We have to say that in Canada and in the US, we do 3 days course full time, but we have very long days there. We start at 8 o'clock till about 6, 7 o'clock. And also together with e-learning in different languages. So let's talk about the domain of CRAFTA where we look to. We look to 4 regions in the head region: craniofacial, cranioneural, craniocervical, and temporomandibular region. And first we try to look to an assessment of these regions. Yeah, we do an assessment, of course, manual, but also with inspection. And then we make a platform for management that can be pain neuroscience education related with orofacial pain and coaching of the patient. And of course, the cooperation, what we already talked about it. And maybe we have to think, has the patient to a dentist first or an orthodontics, or do we have C and pediatrics? So we reflect our examination on guidelines based on the research diagnostic criteria of temporomandibular joint dysfunction, the LDC-TMD. It was established in 1992, but in 2014, it is revised by the group of Schiffman et al. And this is more related also with pain, that we can assess pain in TMJ and give us some basic for diagnostic criteria, and is therefore also very useful for clinicians and researchers. So this is also what we introduce in our courses, but we have to say that the diagnostic criteria of TMJ is not cover everything what we do in musculoskeletal pain. So I give you an example of it. Here you see the axis 1 and 2, what is defined by the DCTMD. On the other side, you have here the axis 1, and the axis 1 is everything what is more, let's say, biological somatic. So you can also see signs and symptoms. You can assess this. So you see that in your clinical examination. But on the other hand, we know also from research that a lot of people who have a long-term head face pain have also a lot of psychosocial complaints, like catastrophizing, depression, kinesiophobia, and that is called the axis 2. So you can assess in the axis 1 and the axis 2. And some people, when they have pain and they score on a physical analytical scale on 6, yeah, you never know if it is more dominantly an axis 1 or an axis 2. I give you 2 examples of 2 patients, what you see here. Both have from the axis 1, the diagnosis atherogenic TMJ axis 1. But this woman, Anna, yeah, she had a popping sound on the left side of her face, and she had a cracking jaw by chewing and eating. This is Ashley, 25 years old, and she said, I have a cracking jaw, and sometimes it hurts. The pain comes, and sometimes it's also on the right side. My face is also swollen and alternates to the neck, and sometimes I have abdominal discomfort and pain. So patients who have the same diagnosis but other complaints. So in this case, we see that Ashley is not really black-white in the axis 2 or the axis 1. So there's another axis which is common, that is the axis 333, and maybe she belongs to this one. So this is, of course, very interesting also when you see patients a lot three times in a week or 2 times in 2 weeks. So you have also to assess the contributing factors. And this is also determined by Slade, yeah, in this book from Cesar Fernandez and John Mesa. Yeah, he also said that TMJ is not an isolated problem. There are a lot of multiple risk determinants, yeah, who have influence on the problem of the patients. So in this case, the axis tree, what I already said, introduced the group of Svensson and Dworkin, where we have to also analyze the risk factors. And this is, of course, for us interesting when you work a lot of musculoskeletal therapy, that you have to analyze and to coach the patient over a longer time. And so if we look again to the management, so we find by Anna, the first patient, a lot of signs and symptoms. So we can also treat it very nice manual with some exercises. This is less by Ashley. So the management is probably the coaching by Anna very short. By Ashley, we take her over a longer time. We have to educate her what pain is, how she can deal with her problem, and maybe she have to look to another specialist. Yeah, so what we see here, right, lower and the lower side. Yeah, so she had probably have to go also to a dentist or an orthodontist or a psychologist. So you find our statements on the CRAFTA.org, where we very clear explain how we treat patients with TMJ. So we are related with the clinical research evidence of the DC-TMJ organization, but we also look to the dysfunction of the individual patient and treat that and reflect it, of course. And we integrate further regions. So we also look to cranial-neural, cranial-cervical, and craniofacial region. There is evidence of what we are doing. This is a wonderful Cochrane review from Susan Amio-Olivio, where we said we have influence when we do manual therapy and exercises on the orofacial region, especially on the TMJ. Yeah, we can change the function, in this case, the mouth opening and the pain. So let's go to the craniocervical temporal mandibular relationship. As I said in the introduction, this mechanism, what is called the trigeminal sensitivity. So that means that when I have a nociception from the cervical spine comes in the trigeminal cervical nuclei, what is lying up till C2 and is a part of the brainstem. This can also be from the temporal mandibular region. So both can accumulate in area and can cause pain and dysfunction. Yeah, so we have here both accumulation, nociception, what can be accumulating, and that can increase in time pain or dysfunction, maybe in the neck, but also in the face, without a clear organic dysfunction. So it is accumulative, yeah, and it is spreading. So it can go in the neck or in the face, or maybe also to the shoulder or the low back. And it is called the extra trigeminal sensitivity. But in this case, the trigeminal region plays a very important part of the complaints of the patient. So this is also where we analyze. We look also where are the most nociception areas coming from. That can be the neck, that can be from the TMJ, maybe also from the eyes, or maybe from cranial dysfunctions. And we start to treat and to manage this. Is there evidence that there's an intense relation between the neck and the TMJ? You find in different articles what you show here. Yeah, that are some cross-section studies, but also clinical randomized trials. So when we look to the craniofacial region, and the craniofacial region is really the cranium, the neurocranium, and the visceral cranium. The visceral cranium is the facial skeleton, but can also be a nociceptive area. We do the same. We can assess this, we can manage this, and we can also deal with consultation to other specialists. So you can compare the human cranium as a balloon. It is a kind of a stress transducer system. You press on it, it has a compliance. So a change of shape that comes back again. So there are a lot of tension and stress in this tissue. So that can we also see by the skull. Also when we push on the skull, we do manual techniques, it adapts. You see that the shape is a little bit changed, and also the tension is changed. And we know also from studies like here from Kohler and Schuler that the dura and the environment around the skull has a lot of nociceptions, what you see here. And also it is known now that a lot of C fibers can penetrate through the skull to the soft tissue extracranially. So if you look to the trigeminal sensitivity and we want to change the trigeminal sensitivity, we can also adapt on the cranium. And that is what we do. And we see in the courses then to register the resistance, what you find. And this has nothing to do with craniosacral therapy, but only with the tissue as a compliance system, which has a rebound, a reaction force on the compliance. And of course, the sensory or physical response, what happens when you push on neurocranium or the visceral cranium, to stimulate the stress transducer or to analyze if there is a nociception. So we want to be very clear also on the causes that we do not craniosacral therapy. We don't judge craniosacral therapy, but we are based on the orthodontic plastic surgery and neurosurgery studies and the pain science. We are focused on functional, biological, pragmatical models, not on biomechanical anatomical models. And we look to the clinical science of rebounds, resistance, and sensory answer. And we are not related with specific structures what we can change, because we are convinced, and also from studies is done, that there is no evidence about this. Of course, we did also some studies in it, and we looked to the reliability, of the 6 tests we do as a standard test to the rebound and sensory answer, and we found a clear correlation between the inter-reliability, but we also look to the difference. Can we distinguish between patients with head neck pain and TMJ pain and control group? So, and it was also seen. So you can read it. I can send you also the article if you are interested. And then we come to the last part, that is the cranial neuropathic pain component. It is interesting how we can divide neuropathic pain, because we see also a lot of patients who have a neuropathic pain, but not really the clear signs and symptoms of neuropathic pain. So we make a clinical classification related on other studies in our profession, and we divide the group in 3 groups. So the neuropathic pain with a sensory hypersensitivity, the compression neuropathies, and the group with peripheral nerve sensitization. So as you know, the pain and the peripheral sensitization can come from the axon. When there's a demyelinization, you get abnormal exit potentials go to centrally, and that can give an accumulation. So if you think on trigeminal sensitivity, you can imagine that the accumulation can be a contributing factor for more pain in the face. Another thing is the nerve trunk. The nerve trunk have C fiber and can increase afferent inflammation to the dorsal horn or the brainstem. And that can increase also the accumulation in the trigeminal sensitivity. And that can become by compression. For instance, when I get a compression neuropathy, there's a compression of, for instance, the masseter on the nerve or the pterolateral muscle on the lingual nerve. There's an increase of conduction changes, but also a change of the afferent input from the C fibers. And this is the scheme we use. So we use also the lens scaler. That's a scale to distinguish between neuropathic pain, where the axon plays a role, so the neuropathic pain sensory hyperactivity. Then we have some questions about the compression, and then the nerve trunk sensitivity. And when we do this, we do first the subject examination, and then a very fine neural examination, nerve palpation, neurodynamic test, and quantitative sensory testing, what you can do, or the bedside testing. So patients who have, let's say, an S-specific face pain, what you see here, where there's a peripheral nerve sensitization, there's a compression together with a C fiber input of the nerves. You see that here by a woman who has operated on a submandibular gland, and there's a lot of connective tissue. One can disturb the hypoglossus nerve. Or this boy who have a trauma in the face, who get a facial paresis together with face pain, but come from the connective tissue of the face, from the facial nerve. Or this one after a clavicular fracture, where there's an anomaly of the accessory nerve with a lot of shoulder pain. Still all, included in neuropathic craniofacial pain. So how do we examine the patient? So we look first to the inventarization of the peripheral nociception. We do an examination, subjective examination, together with questions. We look to the contributing factors and the risk factors. Afterwards, we decided what region we want to examine, cervical, TMJ, craniofacial, cranial, but also we can look to body distortion. We don't talk about it this time, but a lot of facial pain patients longer than 2-3 months have also body disruptions. So they have a sense of feeling what is changed in the face, what can also give, for instance, laterality problems, but also emotion recognition problems. So we look to it, and then we can go to decide, is there a clear trigeminal sensitivity, or is there a gray zone, or is there an extra trigeminal sensitivity? And then we adapt our treatment. So we make a basis for our treatment and further management. So this was a short lecture. I'm not complete, of course, but it gives you an impression we do. So again, I think the CRAFTA is a unique approach. Just other than other TMJ courses or cranial courses or what else. We here think a lot of innovation, cooperation. We investigate also. We do also have a research group what support our lectures and our teaching, and we try to be also innovative, but on the background of the internal evidence and the external evidence. So if you are interested, look to this introduction video you find on the CRAFTA information website in YouTube, or go to the crafta.org website for courses in your country. So I thank you very much, and I hope you will enjoy it. Thank you.